Welcome to the deep dive. This is where we take the sources you've provided, research papers, articles, notes, you name it, and really dig into them to pull out the key insights and information.
Exactly. Think of us as your guides through this material. We'll highlight the important bits, explain what they mean, and help you make sense of it all without getting lost in the weeds.
And today, we're diving into a class of medications that honestly have really shaken things up in treating some major conditions. They started out for diabetes, but wow, the story got much bigger. We're talking about SGLT2 inhibitors. You might know them by their nickname, the Flozins, or sometimes gliflozins.
They definitely have made a name for themselves. And for this deep dive, we're drawing specifically from the sources you gave us. So that's things like recent medical research. There's a 2024 paper in here on kidney transplant patients we'll get into.
Right.
But also broader clinical summaries and, practical patient information like stuff from Diabetes UK and the NHS here in the UK.
So our mission today is to bring all that together. We want to give you a really solid grasp of what SGLT2 inhibitors are, how they actually work in the body, the, frankly, huge benefits they've shown,
Absolutely.
the really important safety things you need to know, and some practical advice based on what's in these guidelines and studies.
And just to reiterate, we're focusing only on the information contained within these specific sources you've shared. By the end, you should have a clear, evidence-based picture based on this material.
Okay, great. Let's jump right in then. Where did these flozins come from, and what exactly are they doing physiologically? What's an SGLT2 inhibitor?
Well, the name gives a big clue. Sodium glucose cotransporter 2 inhibitor. It's a drug that blocks that specific protein. And yeah, the nickname flozin or gliflozin.
Yeah.
It just comes from the end of the generic drug names like dapagliflozin and pagliflozin.
Camagliflozin.
Togliflozins, exactly.
Okay, SGLT2. Where do we find these transporters, and what's their day job, so to speak?
Their main site of action is the kidneys. Your kidneys are constantly filtering blood, and that includes glucose, sugar. Normally, once glucose gets filtered out into the kidney tubules, the body says, hang on, that's valuable fuel, and it reabsorbs most of it.
Right, doesn't want to just pee out all that energy.
Precisely.
Yeah.
And this reabsorption happens mostly in the first part of the kidney's filtering system, the proximal tubules. That's where these SGLT transporters are key players.
Okay.
Now, the sources mention two main types involved in the kidney, SGLT1 and SGLT2. SGLT2 is the big one here. It's found mostly in the early part of the proximal tubule, and it's responsible for hauling back about 90% of that filtered glucose into the bloodstream.
90%. So it's doing the heavy lifting.
It really is. SGLT1 is there too, a bit later in the tubule, and also in the gut, actually. In the kidney, it mops up maybe the remaining 10% or so of glucose.
Got it. So SGLT2 inhibitors, they block that main transporter.
That's exactly what they do. They selectively target and inhibit SGLT2. By blocking it, they stop that normal, efficient reabsorption of, roughly 90% of the filtered glucose.
Meaning more glucose stays in the tubules.
And gets excreted in the urine.
Yes.
It causes glycosuria, literally peeing out sugar.
And that's how they lower blood sugar in people with diabetes.
That's the core mechanism, yes. By getting rid of excess glucose, it helps modestly lower elevated blood sugar levels. It's interesting, though. One of the sources points out something quite surprising.
No.
Yeah, it says that even though these drugs achieve almost complete blockage of glucose reabsorption via SGLT2 in that proximal tubule, the overall measured reduction in how much glucose actually ends up in the urine and the resulting blood sugar lowering is actually less than you might expect. It's less than 50% inhibition of total glucose excretion.
Huh. That is odd. If you block the transporter doing 90% of the work, why isn't the effect on excretion closer to 90%?
It's a good question. The source doesn't fully elaborate on the why, but it might suggest that maybe SGLT1 further down compensates a bit more than we thought, or perhaps there are other limits on how much glucose gets presented or reabsorbed elsewhere. But, the bottom line is they do work to lower blood glucose, which was the initial goal.
And this whole idea making the body get rid of sugar via urine to treat high blood sugar,
Yeah.
It's not entirely new, is it? I think the sources mention a much older origin.
Oh, absolutely. The history is really quite cool. It goes way back, long before synthetic chemistry as we know it, back in the 1800s, around 1835, I think it was. Some Belgian scientists, de Koninck and Stas, sometimes a French chemist, Peterson, gets mentioned too. They isolated this compound called fluorizin. And where did they get it? From the root bark of the apple tree.
Apple tree root bark. You wouldn't think that's where a modern blockbuster drug class starts. What did they find out about it?
Well, initially they weren't looking at it for diabetes, maybe for fever, things like that. The key discovery came later in 1886 with a German physician, Oskar von Mering. He gave fluorizin to dogs,
Okay.
and he noticed it caused them to have glucose in their urine glucosuria. And crucially, he linked this to a decrease in their blood sugar levels.
So von Mering basically stumbled upon the first SGLT inhibitor, a natural one?
Functionally, yes. Fluorizin was doing the job. It was inhibiting SGLT transporters. The problem was, it wasn't selective. It hit both SGLT1 and SGLT2. And from a practical standpoint, it was a non-starter for treating humans.
Why not?
The sources say it had really poor oral tolerance, didn't get absorbed well when swallowed, and caused nasty gastrointestinal side effects. So, interesting science, but not a usable drug.
Right. Proof of concept, but needed refinement.
A lot of refinement. Decades, really. The next big step mentioned in the sources comes much later, in 1999. Japanese researchers developed a compound called T1095.
That was different how?
It was a more selective SGLT2 inhibitor. That was a key breakthrough targeting the main kidney transporter while potentially avoiding some of the broader effects of hitting SGLT1 as well.
Getting closer to the drugs we have now.
Exactly. This really paved the way. Then around 2008, scientists at Bristol Myers Squibb and AstraZeneca developed dapagliflozin. This was designed as a more stable, synthetic version and analog of fluorizin, keeping that SGLT2 blocking effect, but making it suitable as an oral medication.
Wow. And getting it approved wasn't entirely straightforward.
No, it took a bit of time. Dapagliflozin got the green light from the European Medicines Agency, the EMA, in 2012. But the FDA in the U.S. initially didn't approve it that year. There were some safety questions raised during the review.
Oh, okay.
But after more data came in and further review, it eventually gained FDA approval in 2014.
So quite a journey, from apple trees and dog experiments in the 1800s through decades of research, finally leading to these selective oral medications.
It really is a testament to persistence. But as important as that initial glucose-lowering effect was, it turned out to be just the opening chapter for the flozins.
Right, because you mentioned this game-changer moment, something that revealed benefits way beyond glucosuria.
Yes, absolutely. The turning point everyone points to is the publication of the MP-REG outcome trial in 2015. It was a landmark study. It fundamentally changed how we thought about these drugs.
What kind of patients were in MP-REG?
They enrolled over 7,000 adults, all with type 2 diabetes. But crucially, they also all had established cardiovascular disease. So they'd already had a heart attack or a stroke or had diagnosed coronary artery disease, that kind of thing.
Okay, so a high-risk group to begin with.
Definitely.
Ah.
They also had to meet certain criteria for BMI and kidney function, and their HbA1c, their average blood sugar marker, had to be 7% or higher, showing their diabetes wasn't perfectly controlled.
And how's the trial set up?
It was randomized. Patients were assigned by chance to get either empagliflozin. One group got 10 milligrams daily, another got 25 milligrams daily, or a placebo, a dummy pill. And they were followed for several years.
What was the main thing they were looking for? The primary outcome?
The primary outcome was a composite, basically, a combination of three major negative cardiovascular events: death from a cardiovascular cause, a non-fatal heart attack, or a non-fatal stroke. They wanted to see if empagliflozin reduced the risk of any of those three things happening.
And the results. This is where things got exciting.
Incredibly exciting. The results were, well, much better than anyone really expected for a drug thought mainly to lower blood sugar. When they pooled the two empagliflozin groups together and compared them to placebo, there was a clear, statistically significant reduction in that primary composite outcome. The hazard ratio was 0.86.
Okay, 0.86. That means a 14% lower risk of having one of those major events.
Exactly, a 14% relative risk reduction, which is good, definitely significant. But the finding that truly blew people away was about all-cause mortality, death from any cause.
What did they find there?
Patients taking empagliflozin had a dramatically lower risk of dying from any cause during the study compared to those on placebo. The hazard ratio was 0.68.
0.68. Wait, that's a 32% relative reduction in the risk of death from any cause?
Precisely, 32%. It was frankly unprecedented for a diabetes medication at that time. It strongly suggested these drugs were doing something far more protective than just managing glucose.
Wow.
And the source puts it into perspective with the NNT, the number needed to treat. To prevent just one death from any cause, you only needed to treat 39 patients with empagliflozin for 3 years.
39 patients treated for 3 years prevents one death. That really underscores the impact. It shifted the focus, didn't it? From just diabetes management to actual life extension in this high-risk group.
Completely. MPA-REG and then other Big trials like Canvas with canagliflozin and Declare-TIMI with dapagliflozin, they all pointed towards these powerful cardiovascular protective effects, not just fewer heart attacks and strokes, but also fewer hospitalizations for heart failure.
Which naturally led to asking, what about patients with heart failure without diabetes?
Exactly. If the benefit wasn't just about glucose, could these drugs help people whose main problem was heart failure? That led to a whole new wave of major trials specifically in heart failure populations.
And two really stand out in the sources you mentioned, DAPA-HF and Emperor-Reduced.
That's right. Hugely influential trials.
Let's take DAPA-HF first. What was the setup there?
Okay, so DAPA-HF stands for dapagliflozin in patients with heart failure and reduced ejection fraction. It was a large, randomized, double-blind, placebo-controlled trial. Industry-funded, they enrolled almost 5,000 patients.
And what characterized these patients?
They all had symptomatic heart failure, class 2, 3, or 4 symptoms, mostly class 2 meaning mild symptoms on exertion. And crucially, they had a reduced left ventricular ejection fraction, or LVEF, of 40% or less.
Meaning the heart's main pump wasn't squeezing effectively?
Correct. And here's a key point. The trial included patients both with and without type 2 diabetes. About 45% had diabetes, 55% didn't. And almost all of them were already on good standard heart failure therapy, ACE inhibitors, beta blockers, etc.
So they were adding dapagliflozin on top of existing best practice. What were they measuring?
The primary endpoint was a composite again. Either worsening heart failure, which meant being hospitalized for it, or needing an urgent 5E treatment, or death from cardiovascular causes.
And the results for dapagliflozin?
Really impressive. Dapagliflozin significantly cut the risk of that primary outcome compared to placebo. The hazard ratio was 0.74. That's a 26% relative risk reduction.
26% on top of already good treatment. That's substantial.
It really is. And critically, when they looked at subgroups, the benefit was just as strong in the patients without diabetes as it was in those with diabetes.
So that really proved the point. It wasn't just a diabetes drug helping heart failure. It was a heart failure drug, period.
Exactly. It solidified that understanding. The source also notes it significantly reduced both components separately, worsening heart failure events and CV death. And it reduced deaths from any cause, too. Patients felt better, reported better quality of life.
And kidney benefits, too.
Yes, that was another important finding in DAPA-HF, a significant reduction in kidney function decline in the dapagliflozin group. A really broad range of benefits.
What about safety in DAPA-HF? Any major concerns?
Generally, the safety profile looked good. Very few patients stopped the drug because of side effects. Things like severe low blood sugar or DKA were rare. And interestingly, the source notes these serious issues only happened in the patients who also had diabetes.
Okay, so clear benefits, good safety in DAPA-HF. How did Emperor-Reduced to the empagliflozin trial compare?
Emperor-Reduced was similar in design manufacturer-sponsored, randomized, placebo-controlled, looking at empagliflozin in heart failure with reduced ejection fraction. But one source describes the population as generally a bit sicker or having more advanced disease than in DAPA-HF.
How so? What made them sicker?
Well, it enrolled over 3,700 patients. A larger proportion had a very low ejection fraction under 30%. About half had diabetes, similar to DAPA-HF, but almost half had an eGFR below 60, meaning more significant kidney impairment was common at the start. And more of them had been hospitalized for heart failure before, suggesting maybe their condition was harder to manage.
So a tougher group of patients overall. Did empagliflozin still show a benefit?
It did, yes. The primary endpoint was the same composite: cardiovascular death or hospitalization for worsening heart failure. Over about 16 months of follow-up, the empagliflozin group had a 25% lower risk of this primary endpoint compared to placebo. The hazard ratio was 0.75.
Wow, 25% reduction. That's remarkably similar to the 26% in DAPA-HF. Very consistent.
Extremely consistent findings between the two trials with two different drugs. Emperor-Reduced also showed empagliflozin reduced total heart failure hospitalizations and slowed kidney function decline. It lowered the risk of serious kidney outcomes too, like acute kidney injury.
Any specific safety points from Emperor-Reduced?
They did note a higher rate of uncomplicated genital infections in the empagliflozin group, which we'll talk more about later. But importantly, no significant difference in rates of hypoglycemia, amputations, or fractures compared to placebo.
Okay, so two huge trials, DAPA-HF and Emperor-Reduced, both showing powerful, consistent benefits for heart failure patients with or without diabetes. What happens when you combine their data?
Well, researchers did just that. A meta-analysis pooling the data from both trials gave even more statistical power and really cemented the findings.
And what did that combined analysis show?
It confirmed lower rates of hospitalization for heart failure with SGLT2 inhibitors. The absolute risk reduction was around 4%, meaning you'd need to treat about 23 patients, NNT of 23, over the trial durations to prevent one heart failure hospitalization.
NNT of 23 is pretty impactful.
Very. And again, this benefit was consistent, regardless of whether the patient had diabetes across different age groups, whether they had CKD already, their BMI. It held true across the board.
That regardless of diabetes point just keeps coming up. It really shifted the paradigm.
It absolutely did. These became cornerstone heart failure therapies. The meta-analysis also confirmed a significant reduction in all-cause mortality, about 12% dying in the SGLT2I groups versus 14% in the placebo groups. The NNT to prevent one death was 61.
Still very significant.
Yes, and it also confirmed the reduction in adverse kidney outcomes. Serious side effects remained infrequent overall.
So a mountain of evidence for heart failure. And given they work in the kidney, it makes sense they directly benefit kidney health too, right? Not just as a side effect of the heart failure trials.
Oh yes, the evidence for their role in chronic kidney disease, CKD, is described in the sources as unequivocal. They can significantly slow down the progression of CKD.
How do they do that? Is it just the blood sugar effect in diabetics?
No, it seems to be more than that. While better glucose control certainly helps in diabetic kidney disease, SGLT2 inhibitors appear to have direct beneficial effects on the kidney itself. The sources talk about them reducing the pressure inside the glomeruli, those tiny filtering units in the kidney.
Ah, reducing the workload on the filters.
Kind of, yeah. Reducing that internal pressure is thought to be a key way they protect kidney function over the long term, even independent of glucose lowering. It helps reduce stress and inflammation within the kidney structure.
And has this strong evidence translated into clinical guidelines?
Definitely. The sources highlight the KDIGO guidelines, kidney disease proving global outcomes, particularly the 2024 update. They make very strong recommendations for using SGLT2 inhibitors in CKD.
What are the key recommendations? Who should be getting these based on KDIGO?
They give a 1A recommendation that's the strongest level, high certainty evidence for several groups with native kidney disease, meaning not a transplant. This includes adults with type 2 diabetes and CKD, as long as either EGFR, a measure of kidney function, is 20 or higher.
Okay, T2DM and CKD down to an EGFR of 20?
Right. Also, adults with CKD who don't necessarily have diabetes, but who do have significant protein in their urine specifically, a urine albumin to creatinine ratio, UACR, of 200 milligrams or more are also strongly recommended for SGLT2I therapy if their EGFR is 20 or higher.
So, kidney disease with significant protein leak, even without diabetes, gets a strong recommendation.
Yes. And another 1A recommendation. Adults who have both CKD and heart failure should receive an SGLT2 inhibitor, regardless of how much protein is in their urine. Given the dual benefits, it's a very strong indication.
What about people with CKD but less protein in their urine?
There's a 2B recommendation of moderate certainty evidence for adults with an EGFR between 20 and 45 who have less protein in their urine, UACR, below 200 milligrams. This suggests there might still be a benefit, but the evidence isn't quite as rock solid as for the higher proteinuria groups.
And these guidelines are built on trial data, like the renal outcomes seen in DIPA-HF and EMPEROR reduced.
Exactly. Those trials plus dedicated kidney outcome trials like DIPA-CKD and EPIC-Kidney, which specifically enrolled CKD patients, many without diabetes or heart failure, and showed major kidney protection, all feed into these strong KDIGO recommendations.
Okay, so powerful heart benefits, powerful kidney benefits. Any other general advantages mentioned?
Yes. The sources consistently mention two other common effects. A modest reduction in blood pressure, which is likely partly due to the mild diuretic effect of losing fluid with the sugar.
Makes sense.
And some weight loss. That's thought to be mainly due to losing calories in the form of glucose in the urine.
So lower blood sugar, major heart protection, major kidney protection, lower blood pressure, and weight loss. That is quite a list of benefits for one class of drugs.
It really is. It explains why they've become so important in managing these interconnected conditions.
So the evidence is overwhelming for heart failure and native kidney disease. But you mentioned earlier a specific source looking at kidney transplant recipients, KTRs. That sounds like a trickier area.
It has been, yes. The data on using SGLT2 inhibitors safely and effectively in people who've received a kidney transplant has been much more limited compared to the general population.
And why is this group particularly important to study?
Well, developing diabetes after a transplant, post-transplant diabetes mellitus, is unfortunately quite common. And the sources point out that when KTRs develop diabetes, it significantly bumps up their risk of bad outcomes,
Like what?
like losing the transplanted kidney graft loss, but also cardiovascular events like heart attacks and strokes, and even dying earlier from any cause. So there's a real need for treatments that can protect both the graft and the patient's cardiovascular system in this specific group.
Given the benefits seen elsewhere, SGLT2 inhibitors seem like obvious candidates to investigate. Were there earlier studies?
Yes, the sources mentioned some smaller observational studies, and at least one small randomized trial had looked at SGLT2Is in KTRs before this mirror paper. They generally showed what you might expect: improved blood sugar control, some weight loss, lower blood pressure, and they seemed reasonably tolerated.
But not the big outcome data.
Exactly. They didn't have scale or duration to really tell us if these drugs prevented graft loss or major cardiovascular events in KTRs like they do in other populations.
Okay, so that brings us to this limit-all study from 2024, which one source called critical.
Yes, this study is seen as a really important piece in the puzzle, even with its limitations. It specifically aimed to look at the cardioprotective effects of SGLT2 inhibitors in kidney transplant recipients who already had diabetes. And the source notes it followed up on earlier work by the same group that had hinted at benefits in a combined outcome, including graft failure and death.
Tell us about the study design and the patients involved in this 2024 paper.
It was a retrospective study looking back at data from 750 KTRs with diabetes across 6 hospitals in Korea. Median age was around 55, mostly male. About 16% had developed diabetes after their transplant. They made sure to exclude patients who had had very recent heart problems right before the study period started.
Okay, and what was the main outcome they tracked?
They looked at MFI, major adverse cardiovascular events. That composite included heart attack, stroke, hospitalization for heart failure, or death from cardiovascular causes.
And what was the headline finding when comparing those who used SGLT2 inhibitors versus those who didn't in the whole group?
Over a follow-up of nearly 5 years, the rate of MCE was significantly lower in the SGLT2 inhibitor users. It was 4.7% in the SGLT2I group compared to 12.6% in the non-users.
Wow, that's a big difference, less than half the rate. Did they adjust for other factors?
Yes, they did statistical adjustment for baseline differences. After adjustment, the hazard ratio for MACE-E was 0.37.
0.37. So a potential 63% lower risk of MC associated with SGLT2 inhibitor use in this observational data. That's huge.
But a very strong signal, yes. But because it's observational, doctors chose who got the drug and who didn't.
Right.
You have to be careful about confounding. The groups might have been different in ways other than just the drug use.
Right. How did they try to address that? You mentioned propensity score matching earlier.
Exactly. They use propensity score matching to try and create more comparable groups. Basically, they calculate a score for each patient, predicting their likelihood of receiving an SGLT2 inhibitor based on lots of their baseline characteristics: age, sex, reason for transplant, diabetes details, other illnesses, other meds, etc.
Okay.
Then they match patients who took the SGLT2 inhibitor with patients who didn't, but who had a very similar propensity score. The idea is to compare patients who look very similar before one got the drug and the other didn't, trying to mimic randomization as best as possible with observational data.
So comparing with as much as possible, what did the results look like in those matched groups?
They perform matching in different ratios, but let's look at the one-to-one match. Here, NEC occurred in 3.9% of the SGLT2 inhibitor users versus 11.8% of their matched non-user counterparts. The adjusted hazard ratio in this matched analysis was 0.30.
HR of 0.30, so potentially a 70% lower risk in the matched group. Still a very strong finding. Did they report on side effects specific to these transplant patients?
They did look at UTIs. Interestingly, they found no difference in the rate of bacterial UTIs between the groups. However, they did find a higher rate of fungal UTIs, like thrush, among the SGLT2 inhibitor users.
Okay, that higher risk of fungal infections fits with what we know happens due to the sugar in the urine. Now, the source also mentioned limitations of this study beyond just being observational.
Yes, very important caveats. Observational design is the main one. You can only match on things you measure, so unmeasured factors could still bias the results. Another key one flagged is potential immortal time bias.
Right. Explain that again in this context.
In this study, the SGLT2 inhibitors were typically started quite a while after the transplant. The median was over a year later, about 13.4 months post-transplant. But if the analysis starts counting patient follow-up time from the date of the transplant itself, there's this initial period before the drug was started, where the patients eventually treated were immortal in the sense that they couldn't have an event while on the drug because they hadn't started it yet.
Ah, I see. So that drug-free time gets counted for the SGLT2I group, making them look better than they might otherwise.
It can artificially inflate the apparent benefit, yes. It can make the hazard ratio look lower, better than it truly is, if not handled very carefully in the analysis. So while the HR of zero point 0.3 or 0.37 is striking, we need to interpret it cautiously because of this potential bias.
Makes sense. Any other limitations?
They also noted that about 14% of patients who started an SGLT2 inhibitor actually stopped taking it during the follow-up period. This kind of switching or stopping happens in the real world, but it makes it harder to isolate the true effect of continuous treatment compared to no treatment.
Right. It muddies the waters a bit.
It does. But despite all these limitations, observational design, potential bias, drug discontinuation, the source concludes that this LIMB study is still a vital addition to what we know. It provides the strongest signal to date suggesting real cardiovascular protection from SGLT2 inhibitors in this specific high-risk kidney transplant population.
And there might be other reasons these drugs could be beneficial in transplant patients beyond just the heart and kidney effects. Something about the immune system.
Yes, this is a really interesting and emerging area mentioned in the sources. There's growing evidence suggesting SGLT2 inhibitors might have immunomodulatory or anti-inflammatory effects.
How might that work?
Well, the sources mention a few potential mechanisms. They might suppress something called the NLRP3 inflammasome, which is involved in driving inflammation. They might also reduce the release of inflammatory signals, cytokines, from immune cells, perhaps by affecting certain signaling pathways within those cells.
So potentially calming down inflammation.
That seems to be the idea. There's also mention of potential effects on T cells, which are crucial players in the immune system, maybe influencing how they function or develop, and possibly increasing regulatory T cells.
And regulatory T cells help dampen down immune responses, which would be good in preventing transplant rejection, right?
Exactly. Maintaining that immune balance is critical after a transplant. So while it's still early days for this research, the idea that SGLT2 inhibitors might have these favorable immune effects on top of their known cardiorenal benefits is particularly intriguing for the transplant setting.
So putting it all together, the potential cardioprotection from limb, the known kidney benefits that might help the graft, plus these possible immune effects, what's the takeaway message from the source regarding KTRs?
The editorial discussing the LIMB study wraps it up quite evocatively. It says it's time for transplant teams to really consider these pleiotropic benefits, the multiple effects beyond just glucose, and to think about activating the Flozin shield for these patients.
Activating the Flozin shield. I like that. It captures the potential protective role while acknowledging the evidence is still evolving, especially in this specific group.
Precisely. It signals a shift towards proactive consideration based on the accumulating data.
Okay, so we've covered the science, the history, the big trials, and even the specific KTR population. Let's get practical now. Based on the sources, who are these drugs actually for, and maybe more importantly, who shouldn't be taking them?
Right. So generally, SGLT2 inhibitors are prescribed for adults 18 and over with type 2 diabetes. One source does specify that dapagliflozin can also be used in children aged 10 years or older who have type 2 diabetes.
But we know it's not just about the diabetes diagnosis anymore?
No, absolutely not. As we've hammered home, they're often prescribed now because someone has established heart disease, or is at high risk for it, or they have heart failure with reduced ejection fraction, or they have chronic kidney disease. The decision often hinges on that combination of factors.
Okay, now for the flip side, where are they not suitable or definitely contraindicated?
Top of the list. People with type 1 diabetes, that's generally a contraindication.
Why is that? They lower blood sugar. Wouldn't that help in type 1?
The big concern is the significantly higher risk of diabetic ketoacidosis, DKA, and particularly euglycemic DKA, where your blood sugar isn't sky high, but you're still producing dangerous levels of ketones. People with type 1 lack insulin, and these drugs can unfortunately push the body further towards ketone production in that situation. So anyone with type 1 or a history of DKA should generally avoid them.
Okay. Type 1 and previous DKA are clear no-goes. What else?
Severe liver disease is another caution. The dose might need adjusting, or they might need to be avoided altogether. Pregnancy and breastfeeding are definite contraindications, not enough safety data, potential risks. And if you're planning a pregnancy, you need to discuss this with your doctor well in advance.
What about kidney function itself? Obviously, they help CKD, but are there kidney-related reasons not to use them?
Yes, and this is where we see a bit of a lag, perhaps, between the latest research and some general patient info. While the KTR study we just discussed is promising, some sources still list recent kidney or other organ transplants as a reason not to use them. So practice might still be catching up to the emerging data there.
That's an important nuance.
Definitely. Also, people who are on dialysis are generally not candidates. The kidneys aren't filtering enough for the drug to work properly or safely. And the sources mention caution or contraindication if your CKD is caused by specific conditions like polycystic kidneys, lupus nephritis, or ANCA vasculitis. The evidence base might be different there.
Any dietary or lifestyle factors?
Yes, following a very low carbohydrate or ketogenic diet is listed as a reason to avoid these drugs. That type of diet already promotes ketone production, so combining it with an SGLT2 inhibitor significantly increases the DKA risk.
What about infections? We mentioned UTIs and thrush earlier.
Right. If someone has really problematic or frequent recurrent UTIs or thrush infections, these drugs might not be the best choice, as they can make those issues more likely. Taking immunosuppressant drugs is also listed as a caution in some sources, maybe due to infection risk or other interactions. Though again, that contrasts a bit with the potential beneficial immune effects seen in the KTR research.
It really sounds like a thorough individual assessment is crucial.
Absolutely essential. A healthcare professional needs to look at your whole picture, medical history, kidney function, other meds, to decide if an SGLT2 inhibitor is right for you.
Assuming it is, what are the main options available, say, in the UK?
The sources list four main ones: dapagliflozin, brand name Forxiga, canagliflozin, Invokana, empagliflozin Jardiance, and ortugliflozin Stiglatro. They're all usually once-a-day tablets.
And are there combination pills available, mixing these with other diabetes drugs?
Yes, they exist for convenience. You can get SGLT2 inhibitors combined with metformin brands like Zigduo, Vucanamet, Synjardy, and also combined with another class, DPP-4 inhibitors brands like Glexambi and Qtern. Definitely something to discuss with your prescriber if multiple medications are needed.
How should people take them? Any specific instructions?
Generally, just once a day. Try to take it around the same time each day. Usually it doesn't matter if you take it with or without food, except if you're on one of those combination pills containing metformin.
Ah, why the exception for metformin?
Metformin can sometimes cause stomach upset, and taking it with food usually helps minimize that. So if your SGLT2 inhibitor pill also has metformin in it, take it with a meal. Otherwise, follow your prescriber's instructions and always check the patient leaflet.
What if you miss a dose?
If you remember later the same day, go ahead and take it. But if you don't remember until the next day, just skip the missed dose and take your usual dose at the normal time. Don't double up.
Any other practical tips from the sources, maybe for prescribers or patients?
Yes, one source mentions the practical issue of cost or insurance approval, particularly outside the UK. It stresses the importance for prescribers to clearly document all the reasons why the SGLT2 inhibitor is indicated high cardiovascular risk, heart failure, CKD, not just diabetes, as this can help justify the prescription for reimbursement purposes.
So, highlighting the full range of benefits is key for access.
Exactly. Another point is considering SGLT2 inhibitors when other diabetes drugs might have relative drawbacks for a particular patient. For instance, avoiding TZDs in someone with severe heart disease or obesity, or avoiding sulfonylureas in someone elderly or prone to hypos, SGLT2 inhibitors might be a better fit in those cases.
Choosing the best option for the individual's profile.
Precisely. And patient counseling is emphasized as really important, making sure patients understand why they're taking it, how it works simply, and crucially, what side effects to look out for and what safety precautions to take.
What about UK specifics like costs or driving?
The sources note that in England, diabetes medication is free on prescription, but you need an exemption certificate. Elsewhere in the UK, prescriptions are generally free. For driving, the rules for people with diabetes depend on your meds, license type, and individual factors. It's not a simple yes-no with SGLT2 inhibitors, so the advice is to check the DVLA guidance or talk to your healthcare team.
Okay, lots of practical points there. Choosing the right patient, explaining everything clearly, managing access, and giving proper instructions are all vital.
They really are.
Right. Let's tackle the side effects and risks head-on. Like any medicine, these can have downsides.
Absolutely. And it's crucial people know what they are. The sources stress that not everyone gets side effects, and they often lessen over time, but awareness is key for safety.
What are the common ones? Things affecting more than 1 in 100 people.
Well, the most common ones stem directly from how the drug works, peeing out sugar. so needing to pee more often than usual and feeling quite thirsty as a result.
Makes logical sense. What can you do about that?
Stay well hydrated, drink plenty of fluids. If it's really bothersome, definitely mention it to your doctor or pharmacist.
And the sugar in the urine, that leads to infections.
Yes, that's another common one. Thrush or other fungal infections around the genitals. It affects both men and women. The extra sugar provides, well, food for the fungi.
What's the advice there?
Report it to your doctor or pharmacist. These are usually easily treated with standard antifungal creams or tablets. Good personal hygiene in that area also helps. If thrush keeps coming back or is hard to shift, see your doctor.
Any other common issues?
Back pain is listed as common, but there's an important caveat. If you get sudden, severe, or unexpected back pain, tell your doctor straight away, as it could potentially signal something more serious, like a kidney infection.
Okay, so don't ignore sudden back pain. What about feeling dizzy?
Also listed as common. It might be linked to slight dehydration from increased urination, or maybe interacting with blood pressure meds. If you feel dizzy or shaky, the advice is standard. Sit or lie down, don't drive or use machinery. Drinking enough fluids can help prevent it.
And mild skin rashes.
Also possible. An over-the-counter antihistamine might help if it's itchy, but see your doctor if it's persistent or worrying.
Okay, those are the more frequent ones. Now, what about low blood sugar hypoglycemia or hypos?
This is a really critical point. SGLT2 inhibitors, when used by themselves, do not typically cause hypos. They need glucose in the blood to work, so they don't generally drive blood sugar too low on their own.
But the risk changes when they're combined with certain other drugs.
Exactly. The risk of hypos goes up significantly if you're also taking medications that do directly lower blood sugar by increasing insulin action. The main ones are insulin itself and drugs in the sulfonylurea class.
So what's done to manage that risk?
When starting an SGLT2 inhibitor alongside insulin or a sulfonylurea, your doctor will likely recommend reducing the dose of the insulin or sulfonylurea. It's a proactive step to prevent hypos.
What are the warning signs of a hypo people should watch for?
The classic early signs are feeling really hungry, starting to tremble or shake, sweating, feeling confused, or finding it hard to concentrate, sometimes just feeling very tired. If it happens overnight, you might wake up sweaty, tired, or confused.
And what kind of things can trigger a hypo, especially on combination therapy?
Lots of things, potentially. Taking too much insulin or sulfonylurea, skipping or delaying meals, fasting, not eating enough carbs, changing your diet suddenly, doing more exercise than usual without adjusting food or meds, drinking alcohol, especially without food. Even other medications or illness can affect it.
Sounds like you need to be quite mindful. Any prevention tips?
The most basic, crucial advice is to eat regular meals, including breakfast, and try not to skip or delay meals if you're on hypo-causing meds alongside the SGLT2 inhibitor.
And if a hypo happens despite precautions?
Act fast. Always carry a quick source of sugar. The sources mention sugar cubes, fruit juice, not diet, sugary sweets. Artificial sweeteners won't work. You need actual sugar.
Okay, fast sugar first. Then what?
Followed up fairly quickly with a slower-acting starchy carbohydrate like a sandwich, biscuit, or some fruit to help stabilize your blood sugar. If the sugar doesn't help or the symptoms come back, you need to get medical help quickly. And it's wise to tell family and friends what the signs are so they can help if needed. Good advice. Awareness, preparation, quick action. Now on to the more serious side effects. They're rare, but people need to know about them.
Yes, very rare, according to the sources. Maybe less than 1 in 10,000 people, but critically important to recognize. Diabetic ketoacidosis, DKA, is one.
We said it's why type 1s shouldn't take these. Can it happen in type 2?
Yes, it's rare in type 2, but SGLT2 inhibitors do increase the risk, especially under certain circumstances. And it can be that tricky euglycemic DKA where blood sugars aren't dramatically high, making it harder to suspect.
What raises the risk of DKA in someone with type 2 taking these?
Things like having a history of DKA, being acutely unwell, like with vomiting, diarrhea, fever, having surgery, reducing insulin doses very rapidly, or being on a very low-carb or keto diet.
And the warning signs for DKA?
Feeling or being sick, extreme thirst, confusion or unusual tiredness, stomach pain, breath smelling fruity, like pear drops or nail polish remover, and deeper or faster breathing. These usually develop over 24 hours, but sometimes quicker.
If someone suspects DKA, what must they do? The guidance is absolute. Stop taking the SGLT2 inhibitor immediately. If you have ketone testing strips and know how to use them, check your ketones. But most importantly, seek urgent medical help right away. Contact your doctor, go to A&E, don't delay. Some people with type 2 might even carry a DKA alert card.
Stop the drug, get urgent help. Got it. What other serious ones?
Severe dehydration. We mentioned thirst is common, but severe dehydration is different. Symptoms include a very dry, sticky mouth, extreme thirst, feeling very sleepy or tired, passing little or no urine, and a rapid heartbeat. The risk is higher if you're also on diuretics or water tablets. If you get these symptoms, call your doctor or NHS 111.
UTIs can become serious too.
Yes. If a UTI develops into a more severe kidney infection, pyelonephritis, you need prompt treatment. Signs suggesting this include a high fever, feeling cold and shivery, burning pain when peeing, pain in your back or side, or blood in your urine. Again, contact your doctor or 111.
And then there's that other, very rare but very serious infection.
Yes, Fournier's gangrene. It's a severe, rapidly spreading infection of the skin and deep tissues around the genitals and perineum. It's a true medical emergency.
Sounds horrific. What are the specific symptoms to watch for?
The key is the combination: severe pain, tenderness, redness, or swelling in the genital or perineal area, accompanied by a high temperature, or just feeling generally very unwell.
If someone has that combination, severe local symptoms plus feeling unwell fever, what is the absolutely critical action?
Immediately stop taking the SGLT2 inhibitor and get urgent medical attention. Go straight to A&E or call for emergency help. Do not wait.
Stop the drug. Urgent emergency help. Crystal clear. Any concerns about feet?
The sources mention a small theoretical risk, particularly noted with canagliflozin in some trials, of worsening foot problems like ulcers, infections, gangrene, possibly leading to amputations. This is mainly a concern for people who already have diabetes-related foot complications or a history of them. The advice is clear. Continue with all your regular preventative foot care, see your podiatrist, and get any new foot problems like ulcers or infections checked out immediately.
Okay. Now, given all these potential risks, especially DKA and dehydration when unwell, the sick day rules must be incredibly important for these drugs.
Absolutely paramount. The sources really emphasize this. The basic rule is if you become significantly unwell, you should usually temporarily stop taking your SGLT2 inhibitor.
What kind of unwellness triggers stopping?
Things like significant dehydration from vomiting or diarrhea or a high fever, having low blood pressure, especially if you feel dizzy, being admitted to hospital because you're sick before having surgery. If you suspect DKA or Fournier's gangrene, if you get a significant UTI or severe thrush, if you start dialysis or have a kidney transplant, or if you develop an active foot problem like a new ulcer.
So pretty much any major acute illness or intervention.
Yes. These situations increase the risk of complications like dehydration or DKA, so pausing the SGLT2 inhibitor is the safer course. Often, other meds like diuretics and some blood pressure drugs might be stopped temporarily too in these situations.
Should people check blood sugar more often when sick?
Yes, if you self-monitor, increase your checks when you're unwell.
When is it typically safe to restart the SGLT2 inhibitor?
Usually after a short-term illness, you can restart about 48 hours after you fully recovered and are eating and drinking normally again. But, and this is crucial, if you're ever unsure about restarting, always ask your doctor, pharmacist, or nurse first.
Is there any harm in temporarily stopping, according to these rules?
No, the sources specifically reassure that stopping temporarily when unwell, according to the rules, is safe and appropriate. The danger lies in continuing medication when you're sick.
One last rare risk.
Yes. Like any drug, there's a very small chance of a severe allergic reaction, anaphylaxis. Signs include sudden swelling of the face or throat, breathing difficulty, sudden rash. If that happens, call 999 immediately.
And people can report side effects in the UK?
Yes, through the yellow card scheme. It's important for monitoring medication safety.
So the message is clear. Incredible benefits, but you absolutely have to respect the risks, know the warning signs, and follow those sick day rules meticulously for safe use.
That sums it up perfectly.
Well, that really was a deep dive. We went from apple tree roots and the basic science
Through the game-changing trials, showing massive heart and kidney benefits, transforming how we view these drugs way beyond just diabetes.
We looked at the emerging, exciting data in kidney transplant patients, that idea of the flaws in shield.
And covered the nuts and bolts, who they're for, who needs caution, the different types, how to take them, practical tips.
And spent crucial time on understanding the side effects, from the common to the rare but serious, and those all-important sick day rules.
It's about balancing that huge potential benefit with informed awareness of the risks.
Absolutely. And as we've said, and the sources stress, this is all information to discuss with your healthcare professional. Any decision about starting, stopping, or continuing these medications has to be personalized.
Couldn't agree more. Individual advice is key.
So to leave you with something to think about, Given how the story of SGLT2 inhibitors has unfolded so rapidly, from a diabetes drug to a cardiorenal powerhouse, with hints of benefit in even more areas like transplantation, what does the future hold? Are we still just scratching the surface of what these drugs can do, or have we found their main place? How might our understanding and use of this fluorescent shield continue to evolve?
It's a great question. The field is certainly still very active.
Thanks for joining us on this deep dive into SGLT2 inhibitors. We hope this exploration of the sources you provided leaves you feeling well informed. Keep exploring, keep asking questions.